Hi, good morning, everyone. I'm Syed Akhtar from Sultan Qaboos Cancer Center. So in this first session, I will discuss pathology and staging of diagnosis and staging of prostate cancer. I will start with epidemiology of the prostate cancer. How to. Okay, so this is the first slide showing some figures regarding statistics in prostate cancer. Prostate cancer is the fourth most commonly diagnosed cancer in the world. It's eighth most common cause of cancer death. In men's, after lung, prostate cancer is the second most common cancer diagnosed, and it's affected estimated 1.4 million diagnoses in 2020 worldwide. Highest incidence is seen in Australia, New Zealand, North America, and Western and Northern Europe. And as we know, incidence increases with increasing age. Higher incidence after age 65. So in the next slide, you see pie charts of um, worldwide incidence of various cancers and death rates related to these cancers. As you can see from the pie chart on the left, prostate cancer is the fourth most commonly diagnosed cancer. And on the other side of the second pie chart shows cancer-related death, where it is the eighth leading cause of cancer death. In the next slide, you see world map with incidence of prostate cancer worldwide. The darkest shades areas show the highest incidence, which is in North America, Western and Northern Europe, and Australia and New Zealand. The um, uh, light shaded areas show low incidence. However, some of these low incidence figures may be reflective of lack of screening programs rather than true figures. The other factors included in the that can affect incidence includes age of the population and ethnicity and geography. The next slide shows mortality rate worldwide due to prostate cancer. Here you can see that the mortality rate is highest in the southern part of Africa and some parts of Central and South America. And this is probably related to, also related to lack of healthcare facilities and possibility of presentation at the advancing age. The next slide shows statistical data from US. In 2020, 201,082 new prostate cancers were reported and 32,707 males died from prostate cancer. Males had much higher rates of getting prostate cancer than dying from prostate cancer. The next slide shows the rate of new prostate cancers by age group. As you can see from this graph, as the age group increases, the rate of new prostate cancer also increase and is quite high after age 65. Now we'll briefly touch anatomy of prostate gland. More important clinically is zonal anatomy, which is based on histologic classification. I just wanted to remove this. Okay. So the prostate gland is divided into three zones. The most important is peripheral zone, which is located posteriorly. And this is the most important zone because the majority of cancers arise from this zone, up to 70%, 80%. And this is also amenable to digital rectal examination because this is against the rectal wall. The second zone is central zone, which surrounds ejaculatory ducts. It occupies 20% of the prostatic gland tissue. The third zone is transitional zone, which surrounds proximal part of the prostatic urethra, and it occupies 5% of the prostatic tissue. There is also a fourth zone recognized, which is anterior zone or with fibromuscular stroma. It doesn't have that much glands, so it's clinically not important as compared to these three zones. And the central zone has a very low incidence of prostate cancer, 2.5%. But once these cancer arise, they tend to be more aggressive and they tend to involve the seminal vesical tissue. And up to 20% of cancer arise in transitional zone, which will not be palpable by digital rectal examination. Normal prostatic tissue is composed of glandular and stromal component. Prostatic glands are lined by two populations of secretory epithelial cells surrounded by basal epithelial cells. In this high power view on the left side, you see normal prostatic tissue, prostatic parenchyma, where there are normal glands lined by two types of cells, secretory epithelial cells and basal epithelial cells. Basal epithelial cells are important because their presence indicates benign nature of the glands, and if they are absent, it means it's neoplastic glands. Here on the right side, you can see immunohistochemical slide where the benign gland shows surrounding basal cells highlighted by P63 positive stain, while it's missing in the neoplastic gland on the right side. So pathologists look for these four features in the diagnosis of malignancy in prostate cancer: an infiltrative rather than a clustered pattern of acini glands, nuclear enlargement, prominent nucleoli, loss of basal cells, as we saw in the previous slide. Now, prostate biopsy is usually performed because of abnormal digital rectal examination or high PSA level, elevated PSA level. There are two approaches of prostate biopsy. The gold standard is transrectal ultrasound guided biopsy, and the other approach is transperineal biopsy. On the right side, you see a schematic diagram where prostate gland is divided into 12 compartments, and each compartment is usually biopsied. So depending on the protocol, 12 to 14 biopsies are obtained, including transition zone also. As we remember, 20% of the tumor arise from transition zone. Now, Gleason grading system is used for histologic grading of the tumor, which is pattern-based grading system. On the top, you see very well differentiated individual glands, and they are graded as well differentiated. And as they become less differentiated, and they go for moderately differentiated and poorly differentiated as least amount of glandular differentiation. So this is a schematic diagram for originally Gleason described 5 patterns of infiltration and Gleason pattern, and they are usually combined with the most common Gleason pattern and with the second most common Gleason pattern to get Gleason score. Practical in daily practice, pathologists uses only 3 patterns of tumor infiltration, and the first pattern is pattern 3, where pathologists look if all the glands are individual glands and they are discrete, then the pattern Gleason pattern is 3. If everything is like this, then we just double the figure. 3 plus 3 equal to 6, and it will be grade group 1. Um, and the second pattern is pattern 4, where the glands start getting fused and or they show a cribriform pattern, or there are incomplete glands. All these patterns are recognized as pattern 4. And the third pattern is Gleason pattern 5, where cribriform type glands show central comedotype necrosis, or these tumor cells are scattered and infiltrating in individual single cell forms, or there are sheets of cells. All these patterns are recognized as Gleason pattern 5. So combining all these Gleason scores, Gleason patterns, we come to Gleason score 3 plus 4 is equal to 7, where the individual glands are more as compared to Gleason pattern 4, and this is grade group 2. When Gleason pattern 4 is more in proportion than pattern 3, then it will be grade group 3, where Gleason score is reported as 4 plus 3 equal to 7. And then grade group 4 includes all Gleason scores that come with the number 8. And final is Gleason score, uh, total Gleason score 9 to 10, which falls into grade group 5. And here you see only combination of Gleason pattern 4 and 5. So in this slide, you can see the Gleason score, its respective grade group, and its characteristic. So Gleason score 6 is grade group 1, which is less aggressive, very slow growing, low risk. And as you go with more grade grouping, you see grade group 2 is slightly aggressive, grade group 3 is moderately aggressive, grade group 4 is aggressive, and grade group 5 is highly aggressive. So this is very important pathologic diagnosis in relation to prognosis. So, and this one is also incorporated in final prognostic staging of the tumor. This is a sample of pathology report, where pathologist usually includes all these informations, the diagnosis, which is usually acinar adenocarcinoma, conventional. If there is some variant, it will replace the conventional. Instead of conventional, we will mention about the variant. Then there comes histologic grade group 2, and under bracket we give Gleason scoring. Percentage of pattern 4 is important for prognostic and purposes and for management. Cribriform glands, their presence or absence have independent prognostic significance. We mentioned that one. Intraductal carcinoma also has the same. And we also look for presence of any periprostatic fat invasion or perineural invasion, which will indicate extraprostatic extension. And very important is tumor quantitation, number of positive cores out of total number of cores, percentage of prostatic tissue involved by the tumor, and also the positive core with the highest percentage of tumor. Now we come to tumor staging, TNM classification. And here is our 4 diagrams. You can see T1 is a very small non-palpable tumor, T2 is palpable tumor, T3 is tumor extending to the seminal vesicle, and T4 is tumor fixed to the surrounding structures. Now this table shows TNM staging system, both clinical and pathological. In clinical, T1 is clinically inapparent tumor that's not palpable. T2 is tumor palpable and confined within prostate. T3 is extraprostatic tumor that is not fixed and does not invade. And T4 is tumor which is fixed to the surrounding structure. All these stages are further subdivided. T1 is further subdivided into 3 substages, and where T1C is tumor identified by needle biopsy found in one or both nodes but not palpable. T3 is extraprostatic tumor that is not fixed or invade the adjacent structure. This is again divided into T3A, extraprostatic extension, and if it involves seminal vesicle, it's T3B. In pathological tumor staging, there is no T1. It starts with T2, organ confined. T3 is same as the clinical extraprostatic extension. Um, Extraprostatic extension, and T3B is tumor invades seminal vesicle, and T4 is fixed again. For N category, N0 is no positive regional nodes, and N1 is metastasis in regional nodes. For distant metastasis, there are three types: M1A, which is non-regional lymph node metastasis; M1B is bone metastasis; M1C is other sites with or without bone disease. When more than one metastasis is present, the most advanced category is used. M1C is the most advanced. Now, prostate cancers can be broadly divided into three types based on tumor staging: localized prostate cancer, NET, N0, M0. Regional prostate cancer, NET, with nodal involvement, N1, M0. And distant or metastatic prostate cancer, NET, NEN, and with metastasis, M1. For prognostic group staging, these five parameters are used: T status, N status, M status, and PSA level and grade group. So that's why it's important. Grade group is important, PSA and all these. And these are incorporated in this AJCC prognostic groups, as many of you will be familiar. And this describes different combination of these parameters to come to the tumor stage. Of course, for tumor stage 4, A and B, for 4A is nodal disease, and for 4B is metastasis. So this one last slide in these risk groups I added, I took it from NCCN guideline just to show very low to low, intermediate, high, and very high categories. And there are all details and combinations of available information, which includes percentage of number of biopsy codes with less than or more than 50%, which make it favorable, intermediate, or unfavorable intermediate. So these are in details. And the final few slides are, this slide shows stage distribution data from United States. From 2016 to 2020, they found 70% of prostate cancers were diagnosed at localized stage, 13% were found at regional stage, and 8% were found at distant stage. This slide is showing 5-year relative survival and prognosis by stage. You can see that localized cancers had 100% 5-year survival, 99 in regional stage with also has almost 99% survival rate, while distant prostate cancers with distant metastasis fell to 34% 5-year survival. So in summary, the lower incidence of prostate cancer in many parts of developing world, including Middle East, appears due to lack of proper screening rather than true figures. Prostate cancer remains a significant source of cancer-related morbidity in our region, as many patients present with advanced disease. Tumor staging is essential for guiding and devising appropriate management strategies for prostate cancer patients. Understanding of histopathological features is important for prognostic grade grouping, risk stratification, and prognostic staging of the tumor. And finally, localized and regional prostate cancers have excellent prognosis with overall 5-year survival rate of nearly 100%. So that's the end of my talk.